Good afternoon, everyone. We're going to talk about the future of GI bleeding control in 2025. It's going to be very interesting because we're going to talk about innovation a lot in variceal care, AI decision support, and interventional strategies for safer bleeding management. So the emphasis will be on visualization, decision-making, escalation readiness, ensuring that new methods improve outcomes at the bedside. And we're going to start with Christoph Schoenjans, who will talk about variceal hemorrhage in 2025, what's new and what works.
Yes. Thank you. So variceal bleeding in 2025, a big subject to deal in 7 minutes, so I'm going to dive right in. So what works? Pharmacology, endoscopy, and interventional radiology. The first is important with every upper GI or lower GI bleeding is get the patient stable hemodynamically, volume resuscitation, intubate the patient, especially if there's hematemesis, if the patient has altered consciousness. One time a definite therapy beats repeated blind attempts, and especially in cirrhosis patients, extubate them too. Think about asking on the intensive care to extubate them as soon as possible after that. It's also important for the prognosis afterwards. Be restrictive in your blood transfusions, target hemoglobin 7, 8, maybe 1 point higher in cardiovascular disease. And if the INR is higher, the platelets are low, there's no evidence for correcting them. You might even worse portal hypertension if you give fresh frozen plasma. Before you start putting the scope in, there need to be some vasoactive drugs in the patients too, ASAP. Depending on the country where you work in, that can be teliprecine, somatostatin, or octreotide. Some contraindications for teliprecine. Here we usually mainly use teliprecine, or ischemic heart disease, recent cerebrovascular accidents, and peripheral vascular disease. This is given for 5 days. Maybe in less severe episodes, 2 days might be enough. Antibiotics also very important in cirrhosis patients. This reduces mortality, has been proven, ceftriaxone, for example. And then the endoscopy part, early is within 12 hours. Of course, within variceal bleeding, the patient can be unstable. Maybe you feel comfortable doing it a bit earlier. If it's an esophageal